Welcome to this custom-tailored deep dive, designed specifically for you. We are really laying out a mission today to, well, untangle a massive medical mystery.
We really are. It's a complex one.
Right. So imagine you have this blaring fire alarm in your pelvis, just a pain that won't quit. You go to the doctor, they run like every test imaginable, and they swear up and down there is no fire.
But the alarm just keeps screaming.
Exactly. The alarm is still screaming. So today, we're looking at how a really stealthy, persistent bacterial infection can spark that initial fire, and how it leads to a condition called secondary pelvic floor hypertonicity.
Which is essentially just chronic, debilitating muscle spasms.
Right. And more importantly, we are exploring exactly how modern clinicians are finally figuring out how to manage and actually solve it.
Yeah, and we are pulling from a really robust stack of sources to break this down for you today. Our materials include clinical guidelines from the British Association for Sexual Health and HIV, the European guidelines on sexually transmitted infection.
All the heavy hitters.
Exactly. Plus advanced urology and gynecology journal articles and some really cutting-edge physical therapy protocols for chronic pelvic pain.
So the ultimate takeaway we're driving toward today is that sometimes the pain you feel isn't an active disease anymore. It's actually, well, it's the mechanical echo of an infection that your body is frantically trying to protect you from.
Right.
But to understand why that alarm won't turn off, we need to look at the specific invader that started the fire in the first place. And in the clinical guidelines we're reviewing, that initial stark is a bacterium called Mycoplasma genitalium, or MGen.
Yeah, MGen. It's a sexually transmitted bacterium, and it operates entirely under the radar. The statistics and the sources are just striking. Up to 80% of men and 70% of women infected with MGen have absolutely zero initial symptoms.
Oh, really? 80%?
Up to 80%, yeah. It can just sit there in the mucosal lining of the reproductive tract for months, totally silent.
That is a massive portion of the population walking around completely unaware they're even hosting this bacteria.
It is, but, when the bacterial load crosses a certain threshold, or say the immune system becomes compromised, it triggers this cascade of really intense inflammation.
Oh, I see.
In men, this often manifests as non-gonococcal urethritis, which is a severe inflammation of the urethra. And in women, it leads to cervicitis. And if it ascends into the uterus and fallopian tubes, it causes pelvic inflammatory disease.
PID.
Right, PID.
And PID is known to cause really deep pelvic pain, and it could lead to severe fertility complications, right? But the sources point out that treating MGen isn't as simple as just, handing out a standard antibiotic. They actually describe it as a moving target.
It absolutely is. The biology behind that evasion is what makes it so incredibly difficult to eradicate. So standard antibiotics like penicillin, they work by attacking and bursting a bacterium's rigid cell wall.
Okay.
But MGen naturally lacks a cell wall altogether.
Oh, wow. So the drug has nothing to attack.
Exactly. It's essentially immune to an entire class of frontline drugs right out of the gate. And beyond that, it's an intracellular pathogen.
Meaning it goes inside the cells.
Yes, it physically invades and hides inside the epithelial cells of the human host. It uses your own cellular machinery as a shield from the immune system's radar.
Okay, so MGen is basically a squatter who breaks into your house. They don't just sleep on the couch. They change the locks by resisting standard drugs, and then they hide inside the drywall.
That's a great way to picture it.
Right. Hiding inside the drywall is them hiding inside your actual cells.
Mm-hmm.
And while they're in there, they are just completely trashing the living room, causing all this chronic inflammation and PID. The immune system shows up like the police, but they can't even get to them to evict them.
And while that squatter is hidden in the drywall, they are actively modifying the blueprints of the house, too.
Oh, no.
Yeah, MGen mutates rapidly. The sources note that it has developed massive resistance to the backup antibiotics that clinicians usually rely on. It actually mutates its genetic code to block macrolides.
Which are what? Exactly.
Drugs like azithromycin, which normally stop bacteria from building proteins. It also mutates to block fluoroquinolones, which normally stop bacterial DNA replication.
So it's just blocking everything.
Basically. Because of this, the immune system and the standard frontline antibiotics, they just cause collateral damage to the surrounding tissue while desperately trying to get to the bacteria.
So the chronic inflammation just drags on and on. But eventually, a clinician will use a targeted, resistance-guided antibiotic therapy. They might prescribe a sequential course of doxycycline to lower the bacterial load followed immediately by moxifloxacin to finish the job.
Right, exactly.
And then the squatter is finally evicted, the MGen is gone, the tests come back negative, the house is empty.
The pathogen is eradicated, yet the patient returns to the clinic weeks or even months later in excruciating pain.
Which brings us to the real core of this deep dive. The infection is completely gone, so why does the house's alarm system keep blaring?
To understand the pain, we really have to look at how the body is wired. This involves a structural concept called viscerosomatic convergence.
Viscerosomatic convergence. Break that down for us.
Sure. So viscera refers to your internal organs, the bladder, the uterus, the rectum, the prostate. And somatic refers to the muscles and structural tissues. In this case, we're talking about the pelvic floor muscles, which sit like a hammock at the very base of the pelvis, supporting all of those organs.
So they share a physical space, but they also share a neural highway, right?
They share the exact same sensory pathways. Both the pelvic organs and the pelvic floor muscles plug into the exact same segments of the spinal cord, primarily the sacral nerves, S2 through S4.
Okay, I follow.
So when you have chronic inflammation in the organs, like the PID caused by that prolonged MGen infection, the sensory nerves in those organs send massive screaming distress signals up to the spinal cord.
So it's flooding the system.
Right, and the spinal cord receives this overwhelming influx of panic and does what the nervous system evolved to do when under attack. It braces for impact.
It initiates a reflex contraction in the surrounding muscles to, create a shield.
Exactly. We call this muscle guarding. The brain senses danger in the pelvis, so it clamps that hammock of muscles shut tight to protect the inflamed organ.
Okay, wait, hold on. Let me just push back on this for a second because I want to make sure the mechanics are completely clear for you listening. If I get a terrible stomach bug, like food poisoning, my abs will cramp up to protect my stomach.
Sure.
But when the bug is gone a week later, my abs let go. They don't stay permanently cramped up forever. Why does the pelvic floor specifically get stuck like a deer in the headlights long after the MGen is cured?
That's a great question. The distinction here comes down to the chronic timeline and a physiological shift called central sensitization.
Central sensitization.
Right. With food poisoning, the threat passes in a few days. But that MGen inflammation often goes undetected and misdiagnosed for months, sometimes years.
Because it's so stealthy.
Exactly. And when your pelvic floor muscles are clenched constantly for that long, the tissue actually physically changes. The constant, extreme tension literally squeezes the local blood vessels shut.
Oh, wow. So the muscles are cutting off their own blood supply.
They are. We refer to it as local hypoxia. The tissue is suffocating. And without adequate oxygen, the muscles can't function properly. They start accumulating acidic waste products like lactic acid.
Just from being constantly flexed.
Yeah, and this acidic environment physically alters the muscle fibers, causing them to knot up into these painful, rigid trigger points.
So the protective shield actually becomes a weapon against the body.
Precisely. The trigger points start sending their own distinct pain signals back up that shared sacral nerve highway we talked about. So now the spinal cord is receiving alarm signals from both the organs and the suffocating muscles.
A double whammy.
Over time, the central nervous system gets so bombarded that it fundamentally rewires itself. The threshold for what registers as pain drops drastically.
Meaning things that shouldn't hurt suddenly do.
Exactly. Normal, everyday sensations like a bladder filling with urine, sitting down on a hard chair, or sexual activity, they are suddenly interpreted by the hypervigilant brain as dangerous and excruciating.
So even though the MGen squatter is long gone, the nervous system is just completely traumatized. The pelvic floor is locked in a high-tension state, creating this self-sustaining loop of spasm and pain.
Yes.
And this is that secondary pelvic floor hypertonicity the sources emphasize.
And it throws the patient into a really devastating diagnostic trap. You see, the modern medical paradigm is heavily weighted toward finding and killing pathogens.
Hunting for bugs.
Right. So a patient walks into the clinic complaining of severe symptoms. They have deep pelvic pain. They have dyspareunia, which is pain during sexual intercourse. They have severe constipation and constant urinary urgency.
Well, let's break down exactly why those specific symptoms happen. Because the urinary urgency isn't a bladder infection anymore, is it?
No, it's entirely mechanical at this point. The pelvic floor muscles are rigid and constantly spasming. They are physically pressing up against the bladder.
I see.
So the bladder senses that external pressure and just assumes it's full of urine. So it's constantly signaling the brain that it needs to empty immediately.
That sounds miserable. And what about the constipation?
So the pelvic floor muscles actually wrap around the rectum like a sling. To have a normal bowel movement, those muscles have to completely relax and lengthen to open the valve.
Right, they have to get out of the way.
But in a state of hypertonicity, that valve is clamped shut, and pushing just makes the muscles tighten further. As for the dyspareunia, sexual activity involves pressure and friction against muscle tissue that is already suffocating, bruised, and full of those acidic trigger points.
Ouch. But the doctor looking at this patient is just hunting for a bug, like you said. So they run a PCR swab, which looks for the specific genetic fingerprints of bacteria.
And it comes back negative for MGen.
Right. They run a urinalysis,
Yeah.
looking for a standard UTI. Negative. They do a pelvic ultrasound, and the organs look perfectly normal.
Exactly. The fire department is searching the house and declaring that there is absolutely no fire.
Which is crazy to the patient.
The patient is frequently told their labs are quote-unquote normal. So the mechanical symptoms get misdiagnosed as organ diseases. The urinary urgency gets slapped with an overactive bladder label. The pain is just dismissed as unexplained chronic pelvic pain syndrome.
And the sources detail how patients will often get prescribed multiple rounds of broad-spectrum antibiotics just in case there's an invisible infection hiding somewhere.
Which is so damaging.
Right. It destroys their gut microbiome, causes a host of new gastrointestinal issues, and does absolutely nothing for the pelvic pain because the bacteria has already been dead for months.
To escape this trap, clinicians really have to look beyond the internal organs. They must assess the somatic side of that viscerosomatic convergence. Yes. This requires moving past lab tests and performing a manual digital internal palpation. A specialized pelvic floor physical therapist or an informed clinician will manually examine the deep muscles inside the pelvis.
Muscles like the levator ani or the obturator internis.
Exactly.
But these muscles are tucked deep inside the pelvic bowl. I mean, you can't just rub them from the outside like a sore shoulder or a tight calf.
No, they require internal access to assess properly. And when a clinician palpates these specific muscles in a patient with secondary hypertonicity, they don't feel the soft, pliable tissue that should be there.
What do they feel?
They feel taut bands. The muscles literally feel like thick, rigid guitar strings pulled to their absolute limit.
Oh, wow.
And when the clinician presses on those specific knots, the patient's reaction is almost universal.
Yeah.
They recognize the pain immediately. It perfectly reproduces the burning they feel when their bladder is full or that sharp pain they experience during intimacy.
Finding the actual physical source of the pain must be a massive relief for someone who's been told their labs are normal for a year. But the clinical guidelines highlight a massive error that general practitioners often make right at this moment, don't they?
They do.
When they hear pelvic floor dysfunction, their knee-jerk reaction is to prescribe standard pelvic floor strengthening.
Yes, the default medical advice for decades has been to prescribe Kegel exercises.
Which is so backwards. Prescribing Kegels for a hypertonic, locked-up pelvic floor is like trying to fix a tightly clenched fist by telling the person to squeeze their fingers together even harder.
That's a perfect analogy.
You don't need to strengthen the fist. You need to unclench it.
Right. The muscles in a hypertonic pelvic floor are technically weak, but they are weak because they are exhausted. They've been overcontracted 24 hours a day.
Right, they're fatigued.
Exactly. Adding resistance and strengthening exercises to a muscle that is already in a state of chronic suffocating spasm actively harms the patient. It actually increases the physical compression on the major pelvic nerves, like pudendal nerve, and drives the central nervous system further into a panic state.
So we absolutely cannot squeeze our way out of this condition. The clinical blueprint to manage this secondary hypertonicity requires a total reversal in how we approach physical therapy. We have moved from up-training to down-training.
Yes, the absolute first-line treatment is pelvic floor physical therapy focused entirely on relaxation, lengthening, and breaking that pain cycle.
So how do they do that?
Well, the therapist manually releases those deep myofascial trigger points to restore local blood flow. But beyond manual manipulation, they have to teach the patient how to fundamentally rewire their nervous system's connection to those muscles.
Okay.
And this often starts with diaphragmatic breathing.
Which seems disconnected at first glance, honestly.
Yeah.
How does changing the way you breathe unclench a muscle deep in your pelvis?
It's all connected structurally. The respiratory diaphragm in your chest and the pelvic floor act like two ends of a piston. They move in tandem.
A piston. Okay, I can picture that.
Right. So when you take a deep, proper breath into your belly, the diaphragm pushes down. This increases intra-abdominal pressure, which physically forces the pelvic floor hammock to drop, stretch, and lengthen.
Oh, that makes sense. But patients in chronic pain are usually in a state of fight or flight, right? So they take shallow, rapid chest breaths.
Exactly. The diaphragm barely moves, so the pelvic floor stays pulled up and tight.
So changing the breathing pattern is literally the first step to forcing the muscle to lengthen.
It is. And therapists will also utilize clinical biofeedback.
What does that actually look like in practice for the patient?
So the therapist places small electromyography sensors, EMG sensors, either externally around the perineum or internally. These monitor the electrical activity of the muscles. The patient watches a monitor displaying a graph of their own muscle tension, so they can actually see a visual representation of their pelvic floor clenching in real time.
That's fascinating.
It really is. If they feel anxious, they literally watch the line on the graph spike. The therapist guides them through relaxation techniques, and the patient learns how to mentally and physically make that line drop.
It takes this invisible subconscious reflex and makes it visible.
Exactly, allowing the brain to finally learn how to let go.
But the sources outline a major barrier here. What happens when the patient's central nervous system is so profoundly sensitized that they can't even tolerate the physical therapy? Like sometimes the muscle is so inflamed and the nerves are so raw that the mere touch of a therapist causes a severe pain flare.
That is a very common clinical hurdle, unfortunately, and it's exactly where the multidisciplinary approach becomes essential. When conservative downtraining is blocked by severe pain, clinicians escalate to interventional treatments.
Like what?
One of the most effective tools outlined in the advanced urology sources is the targeted injection of botulinum toxin, commonly known as Botox, directly into the pelvic floor.
Okay, hold on. Injecting a paralyzing neurotoxin into the muscles that control our bodily functions sounds incredibly counterintuitive.
It does sound extreme.
People hear Botox and they think of smoothing out forehead wrinkles. But here we are talking about injecting it into the muscles responsible for holding the bladder and bowels closed. The fear of causing incontinence must be huge.
The apprehension is completely understandable. But the mechanics of how it works clarify why it is so effective and remarkably safe. Botox is a neurotoxin that operates precisely at the neuromuscular junction.
Okay.
Normally, your nerves instruct your muscles to contract by releasing a chemical messenger called acetylcholine across a tiny gap.
So acetylcholine is basically the telegraph signal telling the muscle to pull tight.
Exactly. And Botox acts as a pair of molecular scissors. It physically cleaves the proteins needed to release that acetylcholine. It snips the telegraph wire. Without that chemical signal, the chronically spasming muscle is chemically forced to relax.
It literally forces the clenched fist to open. But wait, how do they ensure they're only opening the specific knots causing the pain without paralyzing the entire pelvic floor and causing incontinence?
Precision is key. The clinician doesn't just inject blindly, they use electromyography guidance again.
Oh, the EMG sensors.
Right. They use a specialized needle that acts like a microphone, listening to the electrical static of the muscle. A healthy resting muscle is quiet, but a hypertonic trigger point sounds like a roaring static storm on the audio monitor.
So they literally listen for the exact knot of spasm.
They map out the static and inject the Botox strictly into the localized bands like the puborectalis or the obturator internus. It is highly dose-dependent, and the muscles responsible for maintaining continence are avoided entirely.
Okay, that makes sense.
The clinical literature indicates that the risk of even temporary incontinence is exceedingly low, generally in less than 5% of cases.
That's amazing. So they paralyze the knot.
Mm-hmm.
But Botox isn't permanent, right? It wears off after, what, 3 to 6 months?
Right.
Is the entire procedure just a temporary painkiller then?
Not at all. If a clinician relied on Botox alone, the spasm would likely return once the toxin wore off. The core philosophy of advanced pelvic pain management is that the Botox is not the cure.
And what is it?
The goal is to create a therapeutic window.
A window of silence.
Exactly. By chemically forcing the muscle to relax, you abruptly break that pain spasm pain cycle we talked about. The constant bombardment of pain signals to the spinal cord stops.
So the nervous system can finally breathe.
Right. During this 3 to 6 month window of silence, the local blood vessels open back up, oxygen returns to the suffocating tissue, the central nervous system finally has a chance to calm down.
And most importantly, I'm guessing, the patient can now return to the physical therapist and actually perform the biofeedback and manual release without being in blinding agony.
Exactly. The Botox buys the patient the physical piece needed to retrain their own nervous system. It acts as a bridge to true rehabilitation.
That is just incredible. Let's zoom out a bit and summarize this whole mission for everyone listening. We've explored how chronic pelvic pain demands that we look far beyond the initial infection.
Far beyond.
A stealthy, Cell wall-lacking pathogen like Mycoplasma genitalium might evade the immune system and light the initial match. But long after the bacteria is dead, it's the secondary pelvic floor hypertonicity that keeps the fire burning.
It's the mechanical echo.
Right. Solving this medical mystery means abandoning the old paradigm of endlessly hunting for bugs or prescribing Kegels. It requires looking at the interconnected highway of organs, muscles, and nerves and utilizing physical therapy, biofeedback, and interventional tools to teach a hypervigilant nervous system that it is finally safe to unclench.
And that underlying concept of safety brings us to one final vital layer documented in these clinical guidelines.
What's that?
Well, we have focused extensively on the mechanical response to a physical trauma, the bacterial infection causing inflammation. But the medical literature stresses that we cannot separate the physical spasm from the psychological state of the patient. Muscle guarding is not triggered exclusively by physical pathogens.
Oh, wow. So the nervous system reacts to multiple forms of threat.
Exactly. The central nervous system does not strictly differentiate between a physical threat in the pelvis and an emotional or psychological threat in the environment.
That is wild.
High levels of chronic stress, severe anxiety, and particularly a history of trauma can cause the pelvic floor to reflexively tighten as a primal subconscious guarding mechanism. The sources note a staggering overlap here. Up to 1/3 of patients presenting with chronic pelvic pain syndrome also screen positive for post-traumatic stress disorder.
1/3. That implies that a significant portion of this physical pain has roots in the mind's perception of danger.
It really challenges us to look at pain through a much wider lens. I mean, if a stealthy bacterial infection can cause our pelvic floor to lock into a chronic protective spasm that lasts for years, how much of the unexplained chronic pain we see in clinics is actually the body physically manifesting and holding on to unresolved psychological trauma?
That is a huge question.
We have the physical therapy down training, and we have the Botox to create a therapeutic window. But true, permanent healing might require treating not just the mechanics of the suffocating muscle, but the mind's underlying perception of safety.
It just completely reframes the entire concept of chronic pain. I mean, if the fire alarm is still blaring, it might not just be a malfunction of the pelvic wiring. The body might be keeping score, remembering a fire that nobody else can see anymore. It's a profound reminder that healing is never just about fixing the parts. It is about treating the whole person. Lots to think about today. Until next time, keep diving deep.